Wonderful. Thank you so much, Lynette. This is Caroline Fichtenberg. I'm the Managing Director of SIREN, and I'm honored to welcome you all to the kickoff call of the Gravity Project. This has been several years in the making, and so it's wonderful to have all of you on the call today. It is truly extremely exciting. So if we can go back one slide, the goals of today's call are to tell you about what this project is about with this intriguing name and about how you can be involved. Here's a quick overview of how the call will proceed. First, we'll do some introductions. Then I'll give you a background on the project to tell you more about why we're doing this. Then Evelyn, who I'll introduce in a minute, will walk you through the project scope, or the what of the project, and then the project approach, the how. And then we'll open it up for your questions. As Lynette mentioned, all questions will be taken via the chat feature, which you can find on the bottom of the Zoom screen. And then after we've answered hopefully all of your questions, we will close with next steps. Next slide. So I want to start off by introducing myself and my colleague. As I mentioned already, I'm Caroline Fichtenberg. I'm the Managing Director of SIREN, which is the Social Interventions Research and Evaluation Network at the University of California, San Francisco. Working with me on the Gravity Project from SIREN is Laura Gottlieb, the SIREN Director, and also a practicing family physician at the San Francisco Safety Net Hospital. Next slide. For those of you who are not familiar with SIREN, we're a research and dissemination initiative, as I mentioned already, at the University of California, San Francisco. Our mission is to catalyze and disseminate high-quality research that advances healthcare sector efforts to improve social conditions as part of a comprehensive strategy for improving health and health equity. We do three main things at SIREN. We catalyze high-quality research. We collect and disseminate research findings, and some of you may be familiar already with our evidence library and our monthly newsletter. And we also provide research consultation services for folks seeking help to evaluate their social interventions. So that's a little bit about who we are. I'm going to turn it over now briefly to Evelyn Gallego, who leads the other organization that is facilitating the Gravity Project, for her to introduce herself, her team, and her organization.
Thank you very much, Caroline, and welcome everyone joining us today. We are super excited to have you with us and for all your interest and contributed to this very important work. I am Evelyn Gallego, the Program Manager for the Gravity Project, and with me today I'm joined by Lynette Elliott, whose voice you've already heard, who serves as the Project Manager for Gravity. We have Risham Saeed, who's our project analyst, and Lisa Nelson, who serves as our value sets subject matter expert. So a little bit about EMI. We are a technology and innovation consulting firm that provides data interoperability advisory services across the health and human services sectors. Our team consists of health policy and health informatics leaders that serve as integrators, translators, and guides in helping our clients solve their most complex health interoperability challenges. We have over a decade of experience working on national data interoperability initiatives which bring diverse stakeholder groups together, including a few that have directly supported the Office of the National Coordinator and Health Level 7 or HL7. We are honored to co-lead this project with the SIREN team. And I'll hand it back to you, Caroline.
Thanks, Evelyn. So now that you've heard a little bit more about us, we want to hear a little bit about who you are. I'm seeing a lot of familiar names on the Zoom interface, but I'm also seeing lots that are unfamiliar, which is fabulous. So we're going to do a quick poll right now, asking you to tell us about your primary area of expertise. Lynette, if you want to go ahead and launch it. So it's showed up for me and hopefully it's showed up for everybody else. And so we want to know what do you consider your primary field of expertise, whether it's healthcare, information technology, public health, social services, or something different altogether. Please go ahead and fill that out. And while we're giving you some time to do that, I will just mention one thing. Those of you who are logging into Zoom via browser, I think are not able to see the poll, and I'm really sorry about that. We just realized that at the last minute. We'd love for you to chat in, whether you are healthcare, information technology, public health, social services, or other, into the chat feature. And while you're filling that out, I will also remind anybody who joined us late, we are recording this and all the slides will be made available and the recording after this call. We are also taking all questions via chat. And so please hover on your screen and at the bottom, and a little bar will pop up, I think, that gives you the opportunity to chat. And that's how you should send us any questions that you have about the project as we move forward. Great, so we have the poll results here showing that it looks like the 42% of folks have identified healthcare as their primary expertise, another 28% health IT, about 15% public health, 5% social services, and 10% other. Well, that's a great mix of people and exactly the kind of expertise that we need to tackle the issue of standardizing health IT coding for social risk data. Thank you so much for filling that out. I'm now going to tell you a little bit more about how this project came about and most importantly, why we're doing it. Next slide, please. So I think all of you on this call are probably feeling like we are, that we're in the middle of experiencing a tidal wave of interest in the healthcare sector right now in social determinants of health. This slide shows just a few of the headlines that are coming across our desks on a regular basis that illustrate this interest. Next slide. Of course, this interest isn't coming out of nowhere. It's been spurred by decades of research that have shown that healthcare services only account for a relatively small percentage of our healthcare outcomes, as shown at the bottom of this figure. That the rest of our healthcare outcomes are shaped by health behaviors, the physical environment, and in very large share by socioeconomic factors, the so-called social determinants of health. Social determinants are things such as education, job status, family and social support, income, community safety, and all the other social and economic factors, including racism, that profoundly shape each of our opportunity and ability to be healthy. This new understanding about the causes of health and disease, combined with our realization that although we spend approximately twice as much as other rich nations on health services, we die sooner and have worse health along the way, has unleashed a wave of interest in figuring out how to better address socioeconomic factors as part of healthcare, especially now that healthcare organizations are increasingly being pressured to produce better outcomes and more value per dollar spent. So this has led to this surge of interest in clinical settings in measuring patient social risks, the individual manifestations of the social determinants of health, and using that information about social risks in a variety of ways. Next slide. So at SIREN, we tend to think of the uses of social risk data in healthcare in 6 buckets. First, social risk data can obviously be used to improve medical care by tailoring care to limit the impact of social risks. For example, by selecting the cheapest equivalent medication or conducting visits over the phone to avoid patient copays and other such activities. The second bucket, and we're seeing a lot of interest here as well, are what we call social risk interventions. In other words, activities happening in the healthcare sector that are either directly providing social services, such as food pharmacies or housing supports, or indirectly helping to connect patients with external social service resources to help address social risks. The third bucket is population health management. And this is one I think that gets talked about a little bit, although less than the first two. And this is using social risk data to better target resources to the appropriate patients or help uncover needs for new resources. The fourth, which is related, is risk adjustment, or using social risk data to adjust quality measures or payment. And we're seeing that, for example, in the Massachusetts Medicaid program. The fifth, and I think this is one that tends to not get thought of as much in the healthcare sector, but is dear to me as a public health person, is community health improvement activities. We're using these data to inform community efforts to improve social conditions. And then finally, obviously dear to our heart here at SIREN also, is research, the use of social risk data to conduct research that informs all of these other buckets of activities. So across all of these activities, there's a need to have ways to capture data about social risks and related interventions in electronic health records. Because as we all know, next slide, if it isn't documented, it never happened. Although, next slide, we would go further to say that if it isn't coded, it never happened. If it doesn't get captured in a structured, standardized way in the electronic health record, then the data is generally not going to be used. So that's what this project is all about, facilitating the capture of structured, standardized data about social risks. Next slide. Why do we want to do this? Well, as I mentioned already, to promote the collection and use of the data. If it's not in the EHR and not easily available, it won't be used for any of the types of activities that I mentioned earlier. Second, having data in a standardized, structured format facilitates sharing of the data across organizations, both within healthcare and outside of healthcare. This is particularly important for social risks, given that by definition they relate to non-medical issues, and that interventions will therefore involve non-medical organizations. Finally, having data in a structured, standardized format can facilitate payment for social risk data collection and intervention activities, which we're increasingly seeing state Medicaid agencies looking at and doing. So next slide, this takes us to the question that we asked ourselves at SIREN a few years ago, which is what codes exist to capture social risk data? You've all probably heard about Z codes. These are social risk codes that are included in ICD-10 that are expanded based on the version that had been in ICD-9. And here are a few of them up on the slide. Many of you may also have heard about, and next slide, the social risk domains that were included as an optional component in the 2015 Meaningful Use Certification criteria put out by the Office of the National Coordinator for Health IT. These included the social risk factors that are listed on the screen and that had been identified by a 2014 Institute of Medicine committee that had been charged with identifying social and behavioral and psychological risk factors that should be captured in the EHR. And these are the social risk factors that they had recommended for capture. And in the 2015 edition certification criteria, these were included along with the LOINC codes that could be used to capture screening and responses to questions related to these risks. And LOINC, for those who aren't familiar with it, is one of the several medical terminology systems that are available and used to code medical data. And LOINC is primarily used for capturing screening and lab tests. So when we set out to try to understand what existed in the coding world related to social risks, we did a project a year ago where we looked at 4 different terminology systems. We looked at ICD-10, at LOINC, at SNOMED CT, and at CPT. And we, next slide, looked for codes that related to 20 social risk domains. And these were the 20 domains that were found in the following 6 social risk screening tools that are in wide use in the United States, especially the first 4. And if you want more information about this, the link is at the bottom of these slides. So what did we find? We looked for any codes related to these social risk domains in those 4 code sets. Next slide. It turns out there are a lot of codes that already exist. We found 1,095 codes related to social risks. The majority of them, 686, were assessment and diagnosis codes. And there were about a quarter that were treatment and intervention codes, so codes that captured what kind of treatments or interventions were carried out as a result of identifying screening social risks. There also were some screening question panel codes and a few screening procedure codes. However, despite there being a large number of codes, there actually were very few codes that matched the social risk screening tools increasingly being used in healthcare settings. Next slide. This graph shows the percent of social risk domains in a given tool that had at least one code. You can see that apart from the IOM questions, which as I mentioned already had been included in the 2015 certification criteria, and so of course were fully coded, all of the other screening tools were not well represented by existing codes. The best was the Prepare tool with 43% of domains that had at least one code, but the other ones were lower than that. Next slide. Drilling down now into 3 areas that are of particular interest to the healthcare sector: food insecurity, housing instability, and transportation. Only the AHC, the Accountable Health Community Screening Tool, food insecurity questions had any codes. Questions across these 3 domains for the Prepare and Health Lead screening tools did not have any codes that exactly matched the way the screening questions were asked, and there were no codes across either of these 3 screening tools for housing instability and transportation. So clearly we have issues with missing codes in this area. In addition, we have another challenge illustrated on the next slide, which is the challenge of overlapping codes. Codes that are really similar to each other for the same domain. So here I have from SNOMED, and I'm not picking on SNOMED particularly, these were just the examples that felt that they could be very clear, that we have a lot of codes that look really similar related, for example, to living in temporary shelter or temporary housing arrangements. Then we also have 2 codes there that relate to food insecurity that seem very similar. When should each of these be used? When can they be considered to be all measuring the same concept? These are the kind of questions that this project seeks to address, both these questions about overlapping codes as well as how do we fill gaps. So to address these issues, on the next slide, we've laid out what our goals are for the Gravity project. We're going to be looking for food insecurity, housing instability and quality, and transportation. We're going to be answering the questions: what concepts need to be documented in these 3 domains? What codes reflecting these concepts are currently available? And what codes are missing? And our ultimate goal with this project is to help standardize coding to facilitate data use and operability and interoperability. A note about why we're focusing just on these 3 domains. We are fully aware that these are only 3 of a number of social risks that impede health. However, we wanted to start somewhere, and we thought these were the 3 that are of most interest in the healthcare sector right now. So we wanted to focus on these 3, and once we're done with these 3, a subsequent effort will need to do the same thing for other domains. Before I hand it over to Evelyn to tell you more about how we're going to do this, I want to take a moment to acknowledge that the 2 funders that have made this work possible, Kaiser Permanente and the Robert Wood Johnson Foundation. We're very, very grateful for their support. Medical coding is not always, I know this will be a surprise to everybody on this call, is not always the sexiest thing for people to fund, so we really appreciate the forward-thinking funding of these 2 organizations. I will now turn it over to Evelyn to tell you more about what exactly we're going to do as part of the Gravity project and how.
Thank you very much, Caroline. That was excellent. All right, so I'm going to move over to a very busy visual. So to better conceptualize the goals Caroline just walked through for the Gravity project and get to the meat of what we are trying to accomplish, let's consider the various components and interactions of social determinant of health data users. Our purpose is not to define what technical information mechanisms will be used or how information will flow from one system to another. Our intent is to identify data definitions for social determinants of health concepts, or SDH concepts, that can be documented and shared across the 4 activities of screening, diagnosis, planning, and treatment or interventions, regardless of the initial input system, be it the person or the patient's digital app, the clinical provider's EHR, or the interdisciplinary provider's IT system. We have learned from other clinical standards and workflow initiatives that each of these clinical activities serves as an input to the other, akin to a continuous process improvement model. For example, providers need to evaluate whether the non-clinical intervention they identified for a patient has led to an improved outcome. This merits another evaluation activity, and thereby we start another cycle if the original intervention did not resolve the health concern or social risk concern. We also want to recognize the opportunity this framework has for secondary users of data, such as the public and private payers and researchers whom seek to use the data to inform payment reform, population health, and quality improvement initiatives, to name a few. This brings us to the what of the Gravity Project. Over the course of this year, what we refer to as Phase 1, this public collaborative, meaning all of you on our call today, will focus on 3 primary deliverables. First, we will work collaboratively to develop agreed upon use cases to support social risk documentation across screening, diagnosis, planning, and treatment or intervention activities within EHRs and related systems. Second, we will identify common data elements and their associated value sets to support the use cases. These common data elements will be specific to the 3 domains of food insecurity, housing instability and quality, and transportation access. Third, we will develop a consensus-based set of recommendations on how best to code and group these data elements for interoperable electronic exchange and data aggregation. During Phase 1, we are clear on our scope of work, but we also need to be clear on what is out of scope. So the following activities will not be conducted during this phase. 1, we will not evaluate, test, or harmonize existing screening tools and instruments. We will not look at clinical activities outside of screening, diagnosis, planning, or treatment. We will only focus on the 3 domains we've talked through. We will not pilot or validate the identified data elements. And last, we will not address incentives and workflow issues related to implementation of these elements. So where does the interoperability component come in? The Gravity Project Phase 1 approach and deliverables are purposely designed to allow for rapid uptake into existing and upcoming interoperability and standards acceleration projects. At the end of Phase 1, we will have data definitions for 3 SDH domains and recommendations for coding these concepts in EHRs. For Phase 2, our goal is to supply these structured data definitions for use in existing HL7 initiatives already focused on how to do information exchange between the full range of stakeholders across the healthcare continuum. These include regulators, as an example, through the ONC US Core for Data Interoperability, which has already an emerging data class for social determinants of health. It includes EHR vendors as represented by the HL7 Argonaut project, includes payers represented by the HL7 Da Vinci project, patients as represented by the SIREN project, clinicians as represented by those engaged in the Health Services Platform Consortium, and last, registries and researchers that includes those that participate in the HL7 Clinical Interoperability Council. To support this transition, the data definitions need to be presented and published as coded HL7 FHIR value sets. In Phase 1, we will also initiate development of a draft HL7 FHIR Social Determinants of Health Implementation Guide. During Phase 2, this guide will be refined and updated following the HL7 standards publication process. We have learned an important lesson about data interoperability over the past few years. You need to start with the end clearly in mind, or else all the implementation effort may be wasted. The work on the left you see here describes the data definitions for smoking status and tobacco use included in the ONC US CDI and required as part of the ONC certification program for health IT systems. These coded data elements were not fully vetted or validated by robust stakeholder groups before inclusion in the regulation. Now that most EHR vendors have modified their systems to certify against these specifications and data is starting to flow, researchers at the end of the information exchange chain, as represented here by the HL7 Clinical Interoperability Council, are coming forward to provide evidence about why these required data definitions are not correct and are not what is really needed to document tobacco use. This is the problem the Gravity Project seeks to avoid. Now that we've walked through the why and the what of this project, let's introduce the how. The Gravity Project will be executed as a multi-stakeholder collaborative, facilitated as an open and transparent process using this virtual platform, Zoom, and the HL7 Confluence Wiki. All stakeholders across the healthcare ecosystem are welcome to join, from multidisciplinary providers, payers, implementers, policymakers, consumers, and researchers. As an HL7 project, we will develop deliverables using nationally recognized standard development principles of openness and due process. This will support our interoperability glide path I mentioned in the previous section. Our governance structure consists of an advisory steering committee of 22 individuals representing 17 organizations. The full list of members is published on our Confluence page. Our steering committee provides overall expertise and support in guiding the progress of the Gravity Project. We truly appreciate every single one of them and are grateful for their commitment and leadership in helping us stand up this project, especially getting us to today, and we look forward to working with them over the coming year. Our engagement as a public collaborative consists of a three-prong approach, which brings diverse stakeholders together to achieve consensus on deliverables completed through the course of the project. We've alluded to these three components as part of the deliverables of the project. Each of these builds on the work completed within the previous component. Our first task area is use case development or use case document development. This use case document will consist of personas, a full patient story, and several use cases. Personas, for those not familiar with the term, are fictional characters developed to represent a user type. They are described in terms of their behavior patterns, their goals, skills, attitudes, and background and environment. Multiple personas interact with each other within a patient story. Use cases describe the various interactions personas can have with a system to achieve a specific goal. We'll learn more about personas and use cases during our use case kickoff. But I will note that personas and use cases that we will include will first be prioritized by our steering committee before we present it to the public collaborative. Our second task area is development of the data sets and value sets for the three focus domains we've mentioned. These data sets will be identified within three sequential and separate work streams. This will be the heavy lift for you all who continue to participate in this work because we will need public input on initial data sets to review and discuss together as a group. Our last task area as a collaborative is to develop a final recommendations report that outlines coding gaps and grouping opportunities based on the data sets identified. I appreciate some of these may be new terms for many of you, so please note we do have a glossary and we're looking, and if we talk through terms throughout this presentation that you're not familiar with, we're also going to talk at the end how you can request it be defined within the glossary. Here we visualize the Gravity roadmap for the coming year. Our public three-prong approach is highlighted within task areas 1 and 4, and I appreciate this might be small for some of you to view. As I mentioned in the previous slide, domain data sets will be identified one by one. Collaborative participants can contribute to development of all three, or select the one that is of most interest or within their area of expertise. We will not be branching out into separate work groups. We will just focus these weekly meetings, so we're always going to meet on Thursdays, and when we get to the domains, we'll just focus on each one by one. The agreed upon data sets will then inform development of a final coding recommendations report. In parallel, what you see here under task 5, I want to acknowledge that we will be developing an initial HL7 fire implementation guide that will directly support activities planned for phase 2 of the project. Collaborative participants will be able to review and contribute to this during phase 2, but it will happen in the background. So we will not be talking about the fire IG during phase 1 of the work. All right, so I'm going to stop now. I know you've heard a lot from Caroline and I'd like to welcome questions. So I'll pause there. Lynette and Risham, do we have any questions from the community?
Yes, we do. This is Lynette. There were a couple of questions regarding codes. The first one is from Kevin Nortrup, asking, what about the AMA and United Healthcare plan to add 23 more ICD-10 codes? And Kevin, if I can find you in the list here, I will unmute you in case there's anything you need to add to that. Kevin. Give me just a second here.
Evelyn, do you want me to respond to that?
Yes.
Great. So this, we're very aware of that. And the folks who develop those are actually part of the steering committee for the Gravity Project. And so we will be incorporating that into the work that we do. And we hope that our work therefore helps to provide some validation for those codes. A number of them wouldn't really apply to this project because they're not about food insecurity, housing, or transportation. So those we're not going to review, but where there is overlap, we are going to incorporate them. And as a general point in this work, we want to build on everything that has already been done in this space. So we are reaching out to as many experts and folks who have been advancing this work as we can find to make sure that we incorporate what they've already done and that we build on it. And through this process, help to synthesize and bring together different efforts so that we can have a more standardized approach. Laura or Evelyn, if you want to add anything to that, please feel free.
No, that's a great point, Caroline. I completely agree. I think definitely we're excited to have the UHC and the AMA team on our steering committee. And for those that are relevant to the 3 domains, it's an opportunity that, again, when we get to the domain sections for food insecurity, we can present that back. So that's an example where we say, here are inputs of where the community is documenting or new codes that have been identified, and we could also use this platform, this collaborative, as a validation for them.
And we had an additional question from Aditi Das for, could you please clarify what you mean by medical coding?
Evelyn, I think that one's a good one for you.
Sorry, medical coding, are the code systems? Is that what they're asking about?
I'm not certain. Let me see if I can find.
So well, just as you go, and we do, so just also a preface for next week, we will have Lisa walk through what we mean by the coding systems, what we mean by terminologies, vocabularies, and what is being used. And Caroline also showed the 4 coding systems they looked at. So that's what, when we talk about medical coding, is that when you're documenting an observation or a finding or a result, you have a standard way, usually a number or code that you use to represent that. But again, we'll talk about it more next week. So good that you're asking that question.
Okay, and we have another from Melissa Moorhead. She says, it seems to me that some of those similar codes cited could be different if used to code for an individual condition, say food security, and an environmental or system condition, say inadequate food supply. Is it possible or even desirable to look at both in one system?
This is, oh, Caroline, go ahead.
I can take a stab at that. And Evelyn, maybe you can fill in, or Lisa. So I think, Melissa, I think that's a really good point. And I do think that all of those codes were developed, obviously SNOMED, when they develop codes, they look to make sure that they don't have anything, you know, that they already have that's capturing exactly the same thing. So there's a reason why all those codes were developed. And I wasn't meaning to imply that we shouldn't have all of those. What we hope to do is to try to develop an understanding of which codes should be matched to the ways in which people are currently documenting or capturing this information in clinical settings through screening tools and other activities to identify social risks, and have an agreement, some kind of standards for if we're measuring food insecurity with these questions, this is how it's going to be coded, and also an agreement that regardless maybe of how the questions are being asked, if ultimately they're all kind of measuring the same concept of food insecurity, we can consider some of these codes to be equivalent. So that's the goal of the work that we're going to do, is to really try to delve into that and basically provide a roadmap for vendors, for providers, about eventually, this is not just going to come out of the Gravity project and first phase, it's going to require a second phase, but a roadmap and guidance for a coherent and as complete as possible set of codes that allow for interoperable use of data. Lisa or Evelyn, do you want to add anything?
Caroline, this is Lisa Nelson. I was able to get myself unmuted, and I would like to augment the description that you gave to simply say that next week we'll be talking a little bit about some mechanisms such as data element definitions and value set definitions. And we'll be talking about how those mechanisms allow us to define very specific concepts and hook sets of codes, whether they come from SNOMED or CPT or LOINC, some of the other code systems that were talked about today, so that the combination of the notion and the range of values that apply can be connected together and used in a meaningful way. So in our example where they asked about the difference between the concept that might be applied to an environmental situation as opposed to an individual's situation, we can define different data elements and have a way of expressing and communicating so that the data can be shared in an interoperable way. When we're talking about this concept, it would be relevant to use this set of codes versus when we're describing or sharing this other data element, it would be appropriate to use a different set of those codes from that code system. And the mechanisms called data element definitions and value set definitions that we'll be talking about next week will reveal a little bit more about how we'll do that.
Thanks, Lisa.
Thank you, Lisa.
Any other questions?
Yes, we have several.
Maybe we'll take two more.
Okay. There's a question from Nellie Leon Chison, and I'm sorry if I mispronounced that last name. Isn't there a risk for additional overlap of codes if the proposed ICD-10 codes are implemented before this project is finished?
That is a good question. This is Evelyn. Well, I think there's only 4 or 5, or correct me if I'm wrong, I know Lisa, you've done a deep dive on them, that would be relevant to our project here. What we can do, and I think we have talked to Sheila about whether we can have a way, or in your comments, again, this is, we do have on our Confluence, so this is just for your awareness, we do have the link where you can submit your comments to the CDC in regards to the proposed codes. This is an opportunity we can say we would want to validate it through this process. Those that are, again, specific to the 3 domains we're focused on. But my understanding is they still would not be published till the end of the year. And so it could be an opportunity for revisions, and we can, but again, I think we had that conversation with UHC and AMA about having some way that we can acknowledge that this work is occurring, and we would want a broader community to review them.
And Evelyn, this is Lisa. I will add that most code systems have a fairly long gestational period between versions to release. Some release versions more rapidly, but many of them have a semi-annual or annual release cycle. And so we have that going for us. We also will be working hand in glove with the stewards of these code systems. And so the folks who are responsible for adjudicating requested codes will be very much plugged in to the work that's going on and the evolving analysis that's happening within the Gravity project. And so I think that they'll be tied into our work very closely. And there also is a notion in some code systems of a kind of a maturity level of codes. And sometimes when codes are first released, there is a notion of sort of a trial period. I know with LOINC they have introduced that concept. And so certainly when things are first being introduced, there's always more of a possibility that there may be some revision or refinement to go along with that. But I think that as we collaborate not only with the community that's driving the requirements, but with the stewards that are evolving the code systems, we'll be able to put our efforts together, you know, and really make sure that we come out with the right approach.
Thanks, Lisa. Lynette, I think we have one more, and then I'll finish my next section, and then we'll open up for larger Q&A.
Excellent. This is from Nicole Barbara. Nicholas. I apologize. This is so small, I'm having trouble reading it. From Nicholas Barbara, the heirs taxonomy is currently well leveraged by many social services agencies and by the United Way 211. Do we intend to leverage that taxonomy, especially for treatment codes?
So this is Caroline. I can say that we are aware of it, and it is something that, although we haven't been focusing a tremendous amount of attention on it, but absolutely, if it's relevant and it makes sense, we will look at it. Did anybody else on the team want to add anything about that?
I agree. This is why we're doing this, so we can review as a public collaborative and get many, you know, various stakeholder inputs.
This could be a good moment to say, this is Caroline, that one of the things that we are interested in is knowing about any relevant efforts around standardizing data elements related to food insecurity, housing instability, and quality and transportation that could be relevant for this project. We've done a landscape analysis to try to identify a number of them, but we are sure that there are others that we're not aware of. So we will be making an ask of you at the end of this call to please let us know if there are others that we've missed that we should be aware of.
And this is Evelyn. I'll clarify that next week, Lisa will actually walk through how you can submit those to us. So that will be part of her walkthrough, is how we will have a submission, data element submission template, and she'll give you a sense of how we would want you to fill it out, or how you can start these submissions, because we want to make sure we hear from all of you.
For folks who are interested, this is Lisa Nelson again, for folks who have questions like that about other possible code systems, one of the opportunities that this sort of broad-scale collaboration sets forward is the possibility that code system stewards begin to collaborate with each other. And for example, NANDA, which is a vocabulary that was used in the nursing domain, now collaborates with SNOMED CT, and many of the concepts that were developed and organized in their ontology are now available through SNOMED CT. And so sometimes the answer reveals itself as the code system vendors begin to work together and figure out how to stream these concepts into a way that the standardization community has better access to them.
Okay, thank you, Lisa. So I'm going to get us moving on to the next. We just have a few more slides to go, and then we'll have a more open discussion. So I want to acknowledge, again, walking through the how. Today, marks our kickoff. So it's the first week of our collaborative weekly meetings. We will continue to facilitate these calls as weekly 1-hour meetings using the Zoom platform. Today we scheduled 90 minutes to allow for this discussion, right? So we'll also have discussion after I go through a few more slides. We appreciate there's lots of questions and you're a large group. So, but moving forward, we do want to keep it to 60, although we will keep our line open for 90 minutes. As I mentioned earlier, anyone is welcome to join, and there's no requirement for you to become an HL7 member. However, this is an HL7 project, and I also want to acknowledge that the Gravity project, as of last week, officially became an HL7 Fire Accelerator project. We're finalizing the details, and we'll have a formal announcement. So we are an recognized HL7 Fire Accelerator project, similar to how Karen is and the Da Vinci project. So we do want to encourage, it's not required, but for phase 1, no requirements. But you may want to become an HL7 member, especially as if you want to contribute to phase 2 activities that will go through the full HL7 cycle. All meeting materials will be posted on our HL7 Confluence page, including this presentation and all presentation slides and recordings of the meetings. We appreciate you are all busy. You have full-time jobs, and you may not be able to join every single meeting. So we will be transparent in all our activities. This last point is very important. Of course, we recognize the constraints of engaging so many of you to contribute to a 1-hour public meeting. So for this reason, we will be assigning homework for all of you following every public meeting. This homework will be due to the Gravity Project team by close of business the Tuesday before the next scheduled meeting. I will highlight this more in an upcoming slide. We also have 2 levels of participation for this project, a committed member and other interested party. I want to clarify for those that sign up as committed members, you are not expected to participate in every weekly meeting. We appreciate, like as I said earlier, you have other jobs and commitments, and this is probably one of many initiatives you're engaged in. For that reason, we ensure all meetings are recorded and available on the Confluence. What is expected of committed members is continuous monitoring of this work. So when we complete a deliverable, members have the understanding and knowledge to cast an informed vote. All committed members will be asked to vote on collaborative deliverables. You also have the option to change your status throughout the project. For example, you may be very interested in contributing to the transportation domain. So you may consider signing up as an other interested party while we work on the first 2 domains, and then change your status when we start the transportation work because you would want to vote on that final data set. As I mentioned earlier, our collaborative process will follow HL7 principles of openness and due process. I'm not going to spend too much time on the slide as we have further information on the consensus process available on our Confluence site, and we will spend significant time on this process when we start consensus voting periods. The norms for this collaborative will follow industry-leading principles. So as part of your homework for this week, we encourage those that are not familiar with these norms to familiarize yourselves with them, especially knowing that we are such a large group and we may continue being large for a couple more weeks to come. The link at the bottom provides a nice, I found it a nice concise summary of what these norms mean. So this brings us to our upcoming schedule and activities. Here's a snapshot of what we will be working on as a collaborative for the coming month and what will be assigned as homework to be completed by the collaborative by close of business the Tuesday before the next public meeting. So for today, we are asking by next Tuesday, May 7th, if you have not already done so, join the collaborative, review the collaborative norms, and review the project deliverables that are posted on our Confluence site. And we'll talk about what those project deliverables are. For next week, we will do a deep dive on what we mean by the various concepts used in this project and provide an overview of the coding systems we're referencing throughout this work. And as I mentioned earlier, we will walk through a template we developed to collect your data element submissions for review and harmonization. Week 3 starts our use case development activities, and we'll also spend time walking through each of the use case document components and let you know how each of you can contribute to these as we build out the use case document. Here is a snapshot of our Confluence, where you will find the link to sign up for the project. It is an easy and quick form to fill out. We appreciate that many of you initially signed up for this project, completing the online survey. Thank you for doing that. It really helped for our planning purposes. It was meant to guide how we should facilitate this kickoff meeting. Now we're asking you to complete an additional step, which is to officially join the collaborative, either as a committed member or other interested party. This will help us formalize the group. On our Confluence page, you'll also see upcoming working group meetings and the list of homework materials. So here's just, if you could see on the screen, it lists our homework materials are the project charter, review of the glossary, and review of the relevant standards and initiatives and social determinants of health. These are deliverables, not that we will take comments, and I'll explain in the next slide, or Lynette will walk through what it is. You have 2 ways to submit comments, either on the page or submitting through our general inbox. But these are really, we'd love your comments, your feedback on them, but we are not going to be validating these as a public collaborative. These are things to really just start our project and give you a sense of where we're going. We do see the glossary and the related standards and initiatives as dynamic documents, so we'll continue adding to them as we progress through the project lifecycle. So with that, we are ready for our second and final Q&A session. So Lynette, perhaps you can continue with the other questions you received.
Yes, ma'am. Yes. We had 2 very similar ones come in almost back to back. One from Richard Bookman asking, how do you plan to get patient input? And one from Lucy Johns asking, is there research about how patients perceive and react to social determinants of health questions? And if so, will that be an input to our conversations?
That's a great point. So I'll just start. This is Evelyn. We definitely want, that's why it's open, and we do, we'll look at our list. We do want to have more consumer patient advocates participating in this, that they can contribute, again, to our data set, provide us with input. We do definitely want to get the patient consumer voice. I know there's been a lot of research in that area, and Caroline, I know some of our domain leads have also been doing a lot of work in that area. So Caroline or Laura, anything else for you to add?
This is Caroline. I would just echo what you just said, Evelyn, which is we very much do want patient perspectives, and we welcome them. I think if anyone has suggestions for good ways to engage patient voices to increase that here, that would be great. And so we welcome those suggestions, and there is some research, I would say not a lot, in answer to your question, Lucy, about the research in this area. And we will use all the research that there is to inform this.
Thanks, Caroline. Lynette? Next.
Next, we have many. We have a question from Edward Dick asking regarding the social services code. If we are sending referrals on these 3 items to community-based organizations, would it be good to know that their software is compatible too with the codes? Are companies like MIO that do coding inside the EMR included?
Companies that they should be. This is Evelyn. We want anyone who's involved in coding to be engaged in this effort, and we recognize they may not be the EHR developers themselves. So definitely all those involved in coding, data definitions and concepts in clinical systems should be engaged.
And Evelyn, this is Lisa. I would add that the glide path slide, which showed this Gravity project's content development passing eventually to inform and be used by other initiatives that are focused on the information exchange between different stakeholders' systems positions our work to become absorbed in other HL7 standards that will govern how EHRs and other stakeholder systems would represent and certainly share information. So the value sets that we develop are going to be formatted and formulated in the way that makes them rapidly absorbed by technology that's based around FHIR resources that can have bindings to specific value sets and CCDA templates that support use of and binding to specific value sets. So in that way, this work will become part of the standards that inform all of the systems that different stakeholders use.
Thanks, Lisa.
Thank you. A question from Natalie Martin. Other than prepare, assessments are not built into EHRs, nor are EHRs a preferred solution among the care teams we work with for use of assessments. Are you considering the use of codes in care coordination platforms, or are you focusing on EHRs because you expect to facilitate billing?
It's EHRs and related systems. So if the systems are documenting care or being used to document and generate care plans, we would focus on them as well.
Thanks, Evelyn. There's a question from Dave Hill asking, what is the goal, destination, or repository for the new codes to reside?
Good question. That's way ahead of where we're at, but I do, so Lisa, you could chime in. I expect, as I said in the interoperability glide path, we will publish these as HL7 FHIR value sets, so they would live on the HL7 FHIR value sets page.
Right, and this is Lisa. I would just say that the codes, as they are developed, all reside with the code system stewards, and then value sets that are created off from those code systems can reside in tools such as the National Library of Medicine's Value Set Authority Center, the VSAC, which gives public access to the resulting value sets that would be created. And HL7 has emerging tools called Universal Terminology Guide, I think, I don't know, UTG, that will eventually house FHIR value sets and other value set definitions that are used in HL7 standards. So the codes themselves, really their origin or their concepts reside within the systems that the code systems manage, and then value sets created off of them will be accessible from these other places.
Thanks, Lisa. Lynette, next question.
Thank you, Lisa. Yes. How many, this is from Naveen Rao, how many use case, persona, or patient stories will be developed in step one? For example, one set for each domain of food, housing, or transportation, or will they be cross-domain stories? And how will these be developed? For example, real-world patient interviews or other?
I'll chime in. Right now, there will be cross-story domains. We do not, we anticipate, that individuals can present themselves with more than one, social risk. So we want to tell a story around that and define a use case for that. So just acknowledging again from our timeline, we do have a very short timeline. So we have from now until December. So we really need to be laser focused on our use case development, knowing that it's not going to be perfect. It needs to be, probably more robust use cases can be added. What we intend to do is have an initial set of user personas around one patient story that we can use to help create a use case that can address all the various information exchange needs. So we need to start there, but recognize that there is more work and opportunity to enhance that as we move forward with other phases in this project.
Thank you, Evelyn. And this one is from Peter Eckhart. Can you talk about what's in it for the community-based or human service organizations who typically and historically have provided their services for the 3 domains? Meaning, I think what's in it, what are the benefits of participating in this project, perhaps?
Caroline, do you want to start that first? I can talk about it from a health IT perspective.
Yeah. I think that our vision is that if we all have a better way of sharing information about these needs that's more standardized and we have more interoperable data, that is going to facilitate multi-sectoral, multi-organizational care coordination and the kind of work that facilitate partnerships between healthcare organizations and social services organizations in terms of meeting patient and client needs. I think at a higher level, we think that having a better way of capturing this data is also going to help encourage folks to screen for needs, and is going to give us more data that can be aggregated to identify needs across patient groups and populations that we hope will also help to identify needs that are not being met. And I think we all have a pretty good sense that there are a lot of those out there. But I think having the data captured in the healthcare sector and aggregated through the healthcare sector can complement data that's coming from other sources on these issues and help communities as well as states and other policy levels think about how to best address those needs.
And this is Evelyn. I'll add to, from an interoperability perspective, we want to get to a point where we do become agnostic to the initial data source. So whether it's initially documented in the community-based settings that are already doing this, or in the EHR, we want that data to be able to, as we say, always follow the person. So we want that data to, that it can, if it's initially captured in a community-based setting, or as a, long-term services and supports plan as example, that if that plan is shared with a clinical IT system, that clinical IT system would know how to absorb and reuse those data elements that exist, or those information components that exist in the individual or person's record. So we do want the data to flow across different systems, but for our scope of work is really starting as an initial starting point where there may be individuals that are not receiving community-based services at the moment, or they're not, that's not their initial input into the system. If their initial input is at the clinical setting, then this allows that data to be documented in a standardized way so it can be reused and inform downstream activities. Thank you for your questions. These are awesome. And I'm super excited to still see so many people on the call. Lynette, any other questions? So we are available, and we appreciate this is late on the East Coast, but yeah, we're here to answer questions.
Yes, this one's from Doug Olson. He says, do you foresee any discussions as related to commonalities or differences as the social determinants of health relate to adults or pediatric populations?
So this is Caroline. I'll take a stab at that. So far, no, I think we've been thinking about it in a way to try to be comprehensive. A lot of these, now there are, most of these needs and issues are really at the family level that they're measured. So they're not, although there are some differences in food insecurity, so there's research that shows that if a family has trouble meeting its food needs, generally the parents will go hungry before the children go hungry. So there are some differences in food insecurity within families. But things like housing instability, transportation access are generally the same within a family. But I think that that's something that we should continue thinking about. And definitely as we do the data elements, the use case development and personas, that's one of the things that it would be good to probe and make sure that we take into account if that's something that we should be thinking about differently.
Thank you. And this is Evelyn. I'll add that I know we do have the APA that has been interested in this work. So they also would want to contribute from their lens, from pediatrics lens.
I think you mean the AAP, right? The American Academy of Pediatrics?
Yes, AAP, sorry.
Great.
Thanks, Karen. My acronyms are mixed up. Thank you. AAP.
And I do want to highlight just one thing that I'm reflecting on as I'm listening to all these questions and the way we've structured this. So we have structured this to be very unidirectional right now, that you guys are asking the questions and just a few of us are answering them. But the reason why we have structured this process to be a collaborative, participatory process is that we do not have all the answers in any way, shape, or form. And so even though right now we're giving the answers to these questions, that's just because that's the kickoff call. And the whole point of this project is that collectively, we have the knowledge to answer these difficult questions. So I want to recognize and encourage anybody on the call who has better answers to any of these questions that any of us have had to send us emails about them, give us that feedback. That is the whole point of this project.
Mm-hmm. Absolutely, Caroline. We definitely don't have the answers. And I think part of this too, we recognize we will be learning along with all of you. These are areas where many, based on even the strong interest in this project, is that there's much interest on how we should be addressing this. How should we be using our existing health IT data infrastructure to support social risk documentation? But no one has a concise answer. So it's something that we can work together. Collective minds always work better than one. So we have many minds on this collaborative right now. So we definitely need everyone's input and thoughts, and not focus again on just one particular provider group or one particular stakeholder group. This is really geared to look across the healthcare ecosystem and figure out, if we are documenting this in just one area, how will it impact across? And so we all need you to keep that in mind as we work together.
Time for more?
Yes.
Okay. I'm standing by. This question is from Rajan Sonik, asking, are you considering coding needs by different levels of severity? For example, complex clinical encounters and more severe cases of certain conditions can be coded differently, than simpler encounters and less severe cases.
Lisa, I'll defer that one to Lisa.
Sure. I think that there are notions of those levels of complexity available in the code systems already, and we would look at how to use those modifiers to include as they're used already to augment base codes.
Thanks, Lisa. Lynette, next.
Okay, I'm getting caught up here. Hang on. Let me back up. Okay, this one is from Sarah Green. She asks, how will existing common data models be leveraged to inform this work? For example, PCORNet, OHDSI, and others may already have begun mapping EHR data of their participating health systems to a common vocabulary. Maybe that could help accelerate this work.
This is Evelyn. I'll take a stab. We are familiar with the other data model. That's why we are starting this as an HL7 project and engaging the research community. This is where we would have, we'd look again for your input as we're working through this, if there's mappings already completed. But again, to preface what Caroline emphasized at the beginning, this is an opportunity for us to work as a public collaborative to review these data concepts together. It is an opportunity where what exists right now may not be as we said, may not be the right concepts to document. So if there are mappings already done, how do you know that you're mapping to the right concepts? So those are the things that we want to address through this project, so that we're just not building off something that may have not had robust stakeholder feedback or input.
And this is Lisa. I will add that, as Evelyn mentioned, the Gravity Project is a fire accelerator project, and we will be utilizing data structures established in the fire standard as our common language for data structures. So as other organizations may have modeling that has been done already, the common or base place where we will align all mapping and structures to would be driven around modeling that's available in HL7 fire resources.
Thanks, Lisa. Next, Lynette.
Sorry, I had to unmute myself. This question is from Elkin Salinas. I understand that the project is looking to standardize the value sets exchanged between service providers, both clinical and non-clinical. However, I'm curious to what extent patient consent is going to be taken into account in storing and exchanging this information.
This is Evelyn. That is a great question. So that would be, I would defer, as Lisa noted, we would build off what already exists around patient consent around phase 2. So definitely it would be something we would look at, again, modeling what exists already around patient consent. But for our phase 1, we will just focus on the data definitions.
Thanks, Evelyn. And Matt Stiefel asks, how are you able to standardize the answers if you don't standardize the questions?
Lisa Nelson, Matt, we will absolutely standardize the questions, and you are right on target with thinking about that. In fact, standardizing and understanding, getting on the same place on the question is a first place to start. But the two really go hand in hand. It's kind of a pair. And in order to communicate information, there can be a question with one set of answers, and that same question could have another set of answers, and we just need to know that those are two different things. And moving to a place where we have more discrete coding and specific codes, not only for the answers, but also for the questions, will enable us to distinguish those question-answer pairs from each other, and just make sure that it's clear when we're exchanging information which question and answer pairs we're sharing.
And I just want to add something to Lisa to that, because I think that there are two versions that, of standardizing questions. I think and what we're going to be doing is we're not going to be, when we said at the outset, and Evelyn said as part of what's out of scope, we are not standardizing screening tools. We're not going to be coming up with recommendations for what health systems should screen for. What we are going to try to, or how they should screen, what we're going to try to come up with is, knowing that health systems want to have this information, what are the data elements, and matching those to existing screening tools and questions. But we're not taking on the whole thing of saying, coming up with some universal screening tool that everybody should use. That we're definitely not going to do.
Mm-hmm.
Because that's it's just a big thing. Mm-hmm. However, as Lisa pointed out, I think I'll just add that helping to standardize the data that we want to have, and the coding, not standardize the data, identify a consensus list of data elements, will hopefully help push the field as a whole towards more consensus about what to screen for. But we think that's not technically within the scope of the project to do anything on screening itself.
Thanks, Caroline. This question is from Amy Vreeland. She asks, is open referral or open operability on the radar?
Lisa,
so this is another, oh, go ahead.
No, go ahead, Caroline.
It's certainly on my radar screen a little bit, but I am not an expert in it. Lisa, is this something that you're familiar with?
It isn't on my radar in terms of understanding this specific question.
Great. So my understanding of it is it's another system helping to standardize information and referral information between health care organizations and social service organizations, between social service organizations. It's, I think, more coming from the social service sector. So it's something that should definitely be on my radar screen. Whoever asked that question, if you, when the time comes, want to specifically share your expertise around that, or raise your hand to say that you can help us make sure that we make use of that the best way possible, please do that.
Thanks, Caroline. And this question is from Edward Dick. He asks, our organization and community is considering starting a screening program for these 3 domains, maybe using Prepare or other screening tools. Should we wait until the Gravity project is concluded to avoid wasting time with EHR coding and setup?
Well, this is Evelyn. I would say this is a great opportunity for you to, if you've identified data sets, if you looked across all the screening tools and come up with a subset that's important for your populations, this is a way where you can validate, you know, and as we work through the 3 domains, figuring out which, you know, if those data definitions need to be updated, enhanced, we identify value sets for them that then you can plug into or request your EHR vendor to update.
And this is Lisa. I'll just add, you know, echoing what Caroline clarified about we're not going to be redesigning assessments or changing any questions. When you have concepts and panels and questions and answers that have already been coded through code systems like LOINC and CPT and ICD, those concepts that receive codes from those code systems are managed by the stewards of those code systems for all time. And so there is safety in knowing that if a panel is already defined and there are LOINC codes for those questions and for those answers, they will continue to have that meaning, you know, until LOINC make some different assignment, but there's a great deal of stability from the code systems that they offer. And so I would think that they're, you know, anything that you have access to today that is coded already will remain coded with those code system codes.
Mm-hmm.
Excellent. And this question is from George Dixon as a follow-up to the question earlier about coded severity. Have you plans to provide a model to utilize CDS in monitoring and alerting providers based on system documentation that contains overlapping risks and that may be pre-existing?
Lisa, I would respond that would be a phase 2 consideration.
Absolutely, Evelyn. I was just going to say thank you for the question, George. That is out of scope, however, for phase 1.
Okay. And then this one is from Ramesh. And Ramesh, I'm going to try your last name and forgive me if I get it wrong. Sridharan, asking, are we considering adding some kind of consent module as part of the FHIR data exchange?
This is Lisa. I'll take a first stab at that. There is a great deal of work that is being done around consent within FHIR already, and a family of resources that are devoted that in a large community that is working in that space already. And I would just encourage you to visit hl7.org/FHIR and do some background reading on the consent resource and where that takes you.
Mm-hmm.
Okay, this next question is from Richard Bookman. He asks, will use cases include undocumented individuals or those who might be here without legal status?
This is Evelyn. We do not have that on our use case list right now. So it's something we can discuss internally and with our steering committee.
Okay, and then this question is from Michael Klinkman. Is our scope national or international? Are we intending to solve coding issues for US medical and community care, Or are we planning for this to scale more widely? Revising ICD, for example, may be internationally relevant.
Lisa, I know the codes are international, so we'd have to look across when we get to coding whether some of them are representing international terms as well. I think they're all international.
It does get tricky. I would say we could keep that question in mind, document that, and when we start looking at our code systems, we can entertain that thought and see where the challenges might be.
Mm-hmm.
Okay, and this question is from Dave Hill. In the parallel task of developing a FHIR IG, will there also be tightly coupled implementation of reference implementations and connectathons similar to the Da Vinci project model?
This is Lisa. After, phase 2 and beyond, that's what we intend to feather into. And so what the community has become exposed to through Argonaut and Da Vinci work practices, that's what we will be modeling after. The hope is that this project will not need to reinvent the wheel, and that we will contribute content that will be absorbed into many of the use cases that are already being tested at connectathons, reference implementations that are already being developed in these other projects. They won't have to be redone or reinvented to specifically address social determinants of health. Our content will just plug into the existing infrastructure and testing that's already underway.
Thanks, Lisa. And this question is from Rosie Chang Weir. When codes overlap, how will you decide which codes to recommend, or will you recommend all? I assume this will be addressed in the validation phase.
We'll be gathering community input for codes that the community agrees are appropriate, and then the mechanism of creating a value set enables us to select a range of concepts from a code system that would be appropriate. And so in some cases where there are synonym codes or codes that are nearly identical and could easily either be used, the data element definition allows us to say to a system, if this code or this code appear in the data, it basically means what you can assume to be nearly the same thing, and treat it as meaning in the context of that data element as meaning the same thing. So we will have the mechanism to determine where there are equivalencies that way, and it's really a collaborative approach to see if everybody agrees that way, then that's the value sets that we would put forward.
Thanks, Lisa. And this next question is also from Matt Stiefel asking, Epic now has an SDOH model with a standard questionnaire that links with other Epic functionality, including coding and communication with community organizations. Epic users are currently required to use their exact questionnaire items in order for the response to be interoperable. Do you know what codes they are using and if this project will influence their coding?
Do we have anyone from Epic on?
You'll have to raise your hand because you're all muted. So if you're from Epic, please click your raise hand button. And I will go down the list and see if I see anyone.
Yes, Danielle Friend.
Danielle.
And while you're looking, I will say that, this is Lisa, that Epic is very actively involved in all of the standards initiatives that go on at the HL7 community. And for that reason, I would suspect that they will be engaged both in a participating and actively contributing from their work, and also listening and responding to work that's developed by the community. So it's a give and take sort of process, and I can definitely say Epic is always engaged.
And this is Ellen. I want to, Danielle. Yeah, Danielle, do you want to speak up?
Yeah, so like Lisa said, we're participating in this because we're invested in making this as standard as possible, and so I'm happy to follow up offline if there's, what we can share today on the codes that we use. But we are participating because we want to see this, standardized across the industry.
Thank you, Danielle. Great.
Thank you. Let me check my list again here. All right, and Risham, if you've received any questions that were sent directly to you privately, feel free to jump in here.
No, haven't received any.
Okay. All right, we have one more question, and I think it's appropriate for moving forward with the rest of our presentation. The question is, if I can find it. The question is, what is expected to be the typical homework for team members to complete between meetings?
I'll answer that. This is Evelyn. So it will be review of documents. Initially, for the first 3 meetings, we will be, as we said, Caroline mentioned earlier, we will be presenting because there are concepts we want to introduce. We want to talk through our process. So there'll be things for you to be reviewing, and Lynette will talk about it in a couple of seconds. The other homework will be for you to submit. Like we said, we will have next week, we'll walk through the data element submission form. So we will look for you to start sending us what concepts you're currently using, either, for assessment, across the 4 activities. So that we'll ask that for homework. And then, of course, when we get to consensus period, like there'll be review of the documents and then review of the data sets. And we'll go through all that process. So you'll have a sense every week that before we get to the next meeting, we would hope that you'd come to these meetings prepared, that you've reviewed what we've put up for homework so that you can actively contribute to the discussion. So with that, Lynette, I know we have 1 minute, so I'm gonna
Okay, I will talk quickly. Here's the link for the Confluence. We will be sending out a follow-up email with these links and instructions for what you are asked to do. We will also be issuing the calendar series for the ongoing weekly meetings for the work group meetings tomorrow by close of business. So look for both of those emails in your inboxes tomorrow. You don't have to scribble URLs frantically. We will send them to you. We will ask you to review the project charter glossary and send us any related initiatives that you are aware of. You can submit directly on the Confluence page comment form, or you can email us at gravityproject@emiadvisors.net. You can also email us at any questions. Anything you have on your mind, we will do our best to respond to you all. We had almost 200 people on this call today. So if you all email me, it will take me a little while to answer, but I will. So with that, we will go ahead and adjourn. We thank you all for your wonderful questions and for participating with us today. Look for more information from us tomorrow, and we will go from there. We look forward to talking to you all next week.
Thank you very much, everyone. Thank you.